Hello, welcome back to Fertility Fact or Fiction, our normally weekly show where we review all the latest and greatest in infertility. But I missed you guys for 2 weeks because of graduation for my children, and then we had to do Journal Club last week. So my apologies for not being available for you all for your questions. Instead, this week, we decided not to do a topic so that we could get to all of your questions and answer everything you guys wanted to know. And so, yeah, we are here tonight to address any questions that you may have. Hope you guys have been well. We had a great conference at the Midwest Reproductive Symposium. I am very pleased and happy to say that we were already doing not just what everybody else was doing, but more than what everybody else was doing. And we're kind of ahead of the curve, which we sort of expected and suspected. So that was terrific review. I got to meet up with some friends there and chat with them about what they were doing, learn a little bit about how they're running their practices, and see what people around America and the Midwest are applying in their practices. And it was pretty interesting. We were quite knowledgeable. The coolest part was that I was sitting having breakfast, and some wonderful other folks there joined me. And I said, "Hi, I'm Dr. Victory." And they said, "We know who you are." And they had been fans of the show. So that was really kind of neat. I never in my life expected that to happen, but I guess we're reaching some hearts and minds out there. And so kind of fascinating for me because I'm just an ordinary guy, really, and wasn't expecting to ever get recognized. So anyways, great conference. It's open to everybody. So if you want to join next year, you're welcome to join. And it's back in Chicago every year. It's pretty brief. They do pound us with a lot of information, but a lot of great speakers there and some really important people, and a fantastic talk, which I am trying to get and will probably share in one form or another after she sends me the slides, from Eve Feinberg, who is probably one of the smartest women in all of infertility and one of the smartest people in all of infertility. And she had a great presentation on freezing your eggs. Kind of an eye-opener in many ways. So we'll be talking about that in the weeks and months to come. And yeah, so that's everything on our end. Would love to take your questions. I'm assuming they've been rolling in. So we are going to go with the questions now. My good friend Tarek is here, and we are running on minimal battery. So we'll see. We have a bet going about how long it's going to last. So we'll see if the show starts getting a little hairy. We may jump onto the computer instead of the laptop. Fire away.
Hi, Dr. V and T. I'm about to start the mimicking of FET. Mimicking of FET transfer, as I need to do SIG and ERA. Question below. My doctor said they can either do a medicated ERA cycle with PIO or natural ERA cycle, and eventually natural cycle transfer, given my period is quite regular. And in the natural cycle, they would have me use vaginal suppositories of progesterone rather than PIO. I remember your video mentioned PIO plus vaginal was better, PIO only, and way better than vaginal only. So I am very concerned that my doctor said to do natural cycle with vaginal suppositories of progesterone only. I asked him which one is better and was told the results are the same with either method among women with regular periods. And I don't need both IPO and endometrium, as it doesn't improve outcomes, since in a natural cycle, I get natural progesterone release from the follicles that ovulate. So I just need suppositories to supplement the progesterone that is naturally being produced. Question. This is so different than what you discussed before. What are your thoughts?
Wow. So that is a long question, but a good one. So you're right. The studies that look at progesterone supplementation do look at programmed cycles. So they are hormone replacement cycles, not natural cycles. So in those, you do use progesterone in oil and the suppository. But I mean, if it's good in the program cycle, it should be good in your natural cycle too, as long as you don't overshoot. So that is very important, because in a natural cycle, you're going to also contribute your own natural progesterone, which is going into the uterus and directly into your bloodstream. So you can get overly high levels of progesterone, which is also not good. So as long as they're super careful and titrate your dose appropriately, you could use both. I would recommend using both. If not, I would stick with the progesterone in oil, not the suppositories, because between VAG and PIO, we know that the PIO is definitely stronger. With regards to the ERA test and you doing a mock cycle for an ERA, the ERA test is useless. It has now been proven more times than I can remember to be useless. There is another recent study which again demonstrated that it is useless. Do not do the ERA test. It will not help you. The company that started it just sold it to another company because even they know that it doesn't work. So do not do the ERA test. It's a waste of time and money. That'll save you that whole issue of whether to try it with one version or not. Yeah.
Hi, Dr. V&T. Thank you for your help. I had a successful transfer because of it.
Yes. Awesome.
Any helpful tips on helping to stay pregnant? 6 weeks, 2 days.
Well, at 6 weeks and 2 days, if you've got a heartbeat, you have a very low chance of miscarriage. It's usually less than 2% unless you have a significant history of complications. So stay on your vitamins, your prenatal, definitely vitamin D, the fish oils. Don't do anything exaggerated. Definitely no smoking, no drinking, no drug use, including marijuana. Watch your diet. Don't overeat. And yeah, I mean, aside from that, be as normal as you can be. Things should go well. We do recommend baby aspirin, but we usually start it earlier. So talk to your doctor about it before you start it and make sure that you're a candidate. If you are, that's great. If you're not, then don't do it. And congratulations. That's awesome. I think that's the first time we've high-fived on the show.
It was a great sound.
And it was a good, yeah, it was a good.
It was beautiful. I have to be honest with you. That's a movie maker right there.
All right.
What is the possible reason for no heartbeat around 8 weeks with genetically normal embryos that implanted?
Oh, wow. So first of all, I'm very sorry for your loss. That's totally tragic. And I wish we had a way of avoiding those, but unfortunately we don't. So there could be a variety of different problems. Keep in mind, when you say genetically normal, you're referring to chromosomally normal, but we don't know if it's genetically normal because there can be individual genes that are abnormal that are preventing the embryo from developing normally. So frequently it's actually still the embryo. If it's not the embryo, then it's most likely something about you. And that could be either something like lupus, a thrombophilia, an intrauterine infection, abnormal shape to your uterus like a septum or fibroids, inflammation, autoimmune problems, immunological problems, or sperm. So if the sperm has very high fragmentation, the risk of miscarriage is dramatically increased. We reviewed it on the show years ago. It's 1,183% higher. And that video is like 3 years old now. So we can certainly pull it up for you. But if you have high sperm DNA fragmentation, your risks are considerable. The other possibility, if you're actually doing something, so if you're a smoker, you're drinking, you're using drugs, you're smoking marijuana, all of those will also drastically increase your miscarriage risks. So again, I'm very sorry for what you're going through. My heart goes out to you. If we can help in some way, let us know. But that would be the kind of summation of possibilities for what would be causing a loss at 8 weeks of gestation. And honestly, many times we don't actually know what causes it, but it would break down into the categories of either sperm source, maternal source, or a problem with the embryo.
What do you think about letrozole and natural IVF?
Yeah, there's no reason why you can't use letrozole and natural IVF. If you happen to get 2 eggs out of it, that's a bonus. It's perfectly fine to use. Yeah, there's nothing wrong with that. Do I think you need it? No. But is it reasonable? It's totally reasonable.
Hi, Dr. V&T. I've had 2 failed Euploid embryo transfers and have now just been diagnosed with Crohn's disease. I have 1 embryo left. What can be done to help make this next transfer a success? So
we know that patients with Crohn's disease are much more difficult to get pregnant than patients that don't have that kind of inflammation in their body, and it is an autoimmune condition. So it means your immune system is overactive, and then it's very specific to your pelvis. So it's actually overactive in your pelvis around where all of our action is. So that is a very difficult situation. If you only have 1 remaining embryo, first and foremost, you absolutely must make sure you are in remission. which can take a long time sometimes with Crohn's disease. Secondly, I would go through the immune testing and see what your NK levels are like, your T helper cell levels are like, your cytokines, your interleukins, all of those things, because all of that will be elevated and there may be treatments that you need to help you. The good news, one of the more common things that they use for Crohn's is Humira, and it's one of the best things you can use for fertility patients. So that's a bonus, but there may be other treatments you also need. And then you got to make sure that those treatments don't predispose you to any complications with your Crohn's treatment. So the biggest issue is going to be the delay. It will likely take a long time for you to go into a stable remission. And more important than that is, should you even do it if you only have one embryo left? You have to consider the option of using a surrogate. That's something that I would discuss with you. I hate robbing you of the opportunity to have your own pregnancy, but at the same time, understand that there is no guarantee with this. And if you do end up in a situation where we've tried again and that embryo doesn't work, now you're looking at a whole new IVF cycle. So I would be very cautious and strongly at least consider the merits of using a surrogate.
How much folate do you recommend once pregnancy is confirmed?
Minimum of 400 micrograms, maximum of 5 milligrams. You don't need more than that.
Do we need a referral to see you?
Well, that depends on where you live. So if you're in Ontario, yes. Unless you know you want to do IVF, then you can actually self-refer. If you live outside of Ontario, no. But then you're getting charged for the referral.
Thoughts on ovarian PRP?
Consult. Ovarian PRP? Okay, so ovarian PRP has only one reasonably valid study. And it showed that there was a very small success rate, about 8 to 11%. I actually saw the author, Richard Scott, or one of the authors, Richard Scott, in Chicago, and I sent him an email about it. And I spoke to him about it, and I said, what are your thoughts? And he said, we're not there yet, but it's very promising. So interesting. I'm considering doing it, but it is very, very invasive. It will be very costly if we do it. And I have absolutely no way to know if I'm actually helping people. For stuff that's cheap, even if I'm not 100% convinced it works, but there's reasonable evidence that it works, I'm willing to give it a try. But to do ovarian PRP would likely cost somewhere in the neighborhood of $2,000 or $2,500 for us to accomplish all the stuff that we need for you. I would be very hard pressed to be doing something that costs $2,500 for people when I can't prove that it works. So we don't know yet. And we haven't decided as a team yet if we're going to offer it or not. The one thing that is important about it, it is not designed for women that are older. It is designed for young women that have weak ovaries. I remember one of the first people to introduce it to me was a 48-year-old lady in Toronto who insisted it was the solution to her problems. And my attempting to beg her not to fly all the way to Greece to get this done fell on completely deaf ears. She went all the way out there and it didn't work. And she was very angry at me. And I had tried to talk her out of it, but she was mad that I wasn't being supportive, when in reality, it was very clear that that was not the solution. So if your reproductive age is advanced, it's not going to work for you. You're not going to rejuvenate an ovary that is compromised by the fact that the eggs are genetically abnormal. You may rejuvenate an ovary that prematurely is failing, like a 33, 35, 36. But if you're over 40, it is not going to work for you. So be very cautious about spending large amounts of money to go and buy into this idea when we don't even know if it works at all, let alone in people that are older. How are we on battery, my friend?
The bet is on, bro. The bet is on.
What are we at now?
68.
Oh, hey, I might be out a little money tonight. All right.
Just keep it, you know.
Keep it tight. Yeah. All right.
Hey, Dr. VNT, if someone wasn't able to do an ultrasound until 18 weeks pregnant,
yeah,
is the ultrasound to determine the due date in the second trimester more likely to have a due date later or earlier? than what the due date would have been if it was done in the first trimester? Thank you.
That's a great question. So we can't tell you if it's more likely to be earlier or later. It depends on the growth of your baby. All we can tell you is that it is less accurate in the second trimester than it is in the first trimester. So your most accurate time frame for dating a pregnancy is between about 5 to 7 weeks. And then it becomes progressively wider in the confidence intervals the further you get into the pregnancy. So at 20-week scan, you have about a 2-week 10-day to 2-week error in the dating. So they can't tell you if it's minus or it's plus, just that it's plus or minus 10 days. So we wouldn't be able to tell you which one's more likely. If you have a big baby, it's going to measure you ahead. And if you have a smaller baby, it's going to measure you behind.
Is magnesium helpful for FET prep? I have PCOS.
Not that I've ever read, seen, or heard about. More of a naturopathic question. If Jen Strong is watching, Jen, can you tell us if magnesium is beneficial for an FET prep?
Thoughts on endo excision after retrieval before transfer?
Yes, huge fan. So I have always advocated for this. There was this amazing speaker at the Chicago conference who said, had a whole presentation on this and said, people have been going away from surgery, but the evidence is very clear that there are many benefits from doing surgery for a variety of different conditions for fertility. And therefore, we advocate for doing it because, it can help. So if you have fibroids, there are certain circumstances where removing them helps. If you have endo, we know for sure that removing your endo helps. The EndoCan study showed that. So there are many instances in which surgical treatment prior to an embryo transfer can be beneficial. Endometriosis is probably the foremost amongst those. Fibroids also up there, polyps, fibroids, that kind of thing. So yes, definitely get your endo ablated or excised. There actually is no difference. So don't listen to the people that say you have to have excision. That's just categorically not true. You can just get it ablated or excised. And then you need suppression after that as well in order to facilitate your best chances for a successful transfer.
Best way to prepare your body for an FET?
Boy, Tara could probably answer that one by now. Okay, diet, Mediterranean. Exercise, HIIT training, at least every day or, several times a week, 4 or 5 times a week. Minimum kind of 25, 30 minutes. You want to be doing cardio and muscle building at the same time. No smoking, no drinking, no drug use. Meditate. That's been shown to be beneficial. Yoga has been shown to be beneficial. Acupuncture, if you think it'll relax you, because that can also help. Lots of vitamins, melatonin, baby aspirin, vitamin D, fish oils, folate, iron. Am I missing anything? That's probably about everything. Oh, sex. Have lots of sex. The ejaculate in the vagina actually helps improve the chances that the embryo will stick. So that's definitely very beneficial as well.
Screen's dim, so takes a little bit of extra focus today. What are the best things to take to support a frozen embryo transfer?
So best things to take a frozen embryo transfer, all the ones I just mentioned literally a moment ago, all of those things will help. So all the vitamins, melatonin, vitamin D, you want to take baby aspirin, your fish oils, your prenatal vitamin, your folic acid, and your iron. No smoking, no drinking, no drug use, exercise, the Mediterranean diet, stay calm, meditate, do yoga. All of those things will help prepare you for an FET.
Can you test for NK cells locally? I only did the microbiome fertility test and don't have the money to pay for the autoimmune component currently. I'm in Ontario.
I don't know about locally, but I do know it can be done. I'll find out for you. Why don't you DM me and we'll find out this week.
Hi, Dr. B&T. Can IVF be done for people who removed their tubes or just for people who got their tubes tied? Thank you.
It doesn't matter. You don't need your tubes. So whether they're removed, tied, damaged, whatever, IVF can be done for you. So that's a good question. But we have lots of people that actually had their tubes removed and then decided later they wanted more babies, relationship change, or just change of mind or whatever. We have people that had ectopics on both sides. They needed their tubes removed. We have people with damaged tubes. They got their tubes removed. There's all sorts of different options. So yeah, you can definitely get it done.
Thanks, Dr. VNT. Can sperm fragmentation be detected as part of a semen analysis and or PGTA test?
It cannot be detected as part of a PGTA test, but it definitely can be detected with the right type of semen analysis. So it's semen analysis conventional is just measuring the numbers. Your DNA fragmentation is a separate test conducted in a separate way, but you can use the same sample to do both. Sure.
I'm looking to do an immunology testing with fertilicists.
Awesome.
If issues are found, will they recommend a treatment protocol? And
Yep.
if yes, how do I do that if my RE doesn't believe in immunology?
You know what? I've been seeing so much of that. We got a lot
Doesn't believe in immunology?
Yeah, we got a ton of Americans coming to us last week who, or Europeans, several, all of whom said the same thing. They said their RE won't do it because they said it was all nonsense or BS or hocus pocus or whatever. Yeah. Listen, fertilicists will give you recommendations, although they always give the same recommendation, which is LIT and LIT. There are more options available to you. My advice would be to contact us, do a consultation with us, and then we can help you. The big question is if you are in Ontario, it's not a problem. I can arrange for stuff. If you are out of Ontario but still in Canada, I can probably arrange for stuff. If you are in the US, we need someone that'll cooperate, or you just come to us and we do it here. So we have loads of American patients coming here to our clinic because we're so much cheaper than everybody else. Just this weekend, I spoke with a lovely couple who are considering another fertility specialist in the US who shall remain nameless because I truly like this individual. This is a wonderful person with a huge amount of heart and compassion and love, and has a great program, but they are charging $8,000 US for an embryo transfer, which I didn't know. That's a lot. So, I mean, if you want something less expensive, there are lots of options available to you. And if you, want something that is close, then it may be worth investing that money. And certainly this individual is amazing, so they're probably worth every penny, but that is a lot. So, factor all of that in when you're considering what you want to do and where you want to do it.
Can I get a TB test while pregnant? I'm 8 weeks, 2 days.
Yes, you can get a TB test while pregnant. Actually, you know what? Somebody asked me that yesterday, the day before yesterday on OB day, yeah. Mm-hmm. Or yesterday. Yesterday was Monday.
Yesterday was Monday.
Yesterday.
Today's Tuesday.
Yeah.
Tomorrow, Wednesday. Success rate of natural IVF, no stims. 31 years old and male factor.
31, depending on how bad the sperm is, with just natural IVF for one egg, I'd probably say about 30, 40%, somewhere in that neighborhood would be a realistic guess.
Is it unsafe to take letrozole for a long period of time, 2+ years, on and off? Concerned with thin lining every month. Thanks.
No, but I mean, that doesn't make sense. If you've been trying for 2.5 years, you need to do something more than letrozole. Clearly, it's not working. So you need to see one of us and we need to help you, but there's no harm from taking letrozole every month.
Are there any signs or ways to know if the baby will have no heartbeat or an empty sac at 8 weeks? I'm basically a nervous wreck before the ultrasound tomorrow.
Just slow rising beta and an initial low beta. Both of those can be predictive, but aside from that, no, there's nothing else that is worrisome. So if your initial beta is low and it is still doubling, after that, it does still predict a higher risk of miscarriage. Aside from that, no, there's nothing else that is really detectable. We don't make our patients wait till 8 weeks typically, but it depends on the case. So
IVF stims, medication, and cancer risk question.
Yeah, it's being looked at many times, and there is no risk. And we've actually got 2 videos on that showing that there is no risk. So I don't remember what it was called. It was a while back on Fertility Fact or Fiction, but Tarek and I, one of these days, are going to sit together and rename all of our videos so they're easier to access. But yeah, there is a video from Fertility Fact or Fiction, probably, I would say like a year and a half ago, where we reviewed that, and there's no risk from taking the meds.
If endometriosis is found under laparoscopic surgery, what is the plan for treatment and before a frozen embryo transfer?
So either ablate it or remove it, and then go on Lupron and Letrozole for 3 months while taking NAC, the supplement, curcumin, which is turmeric in powder form that you can swallow, resveratrol and coenzyme Q10. And then when you go to do your actual protocol to prep for the FET, virtually no estrogen, very, very low levels of estrogen. That will activate your endometriosis the least amount possible, and that's what you're looking for. So we use a letrozole-based STIM protocol, and that tends to get us very good results.
Hi, Dr. V and T. What's the pros and cons between medicated versus natural cycle? How to know which one is better?
So it's one of the big controversies in the fertility world. So there are a lot of articles that say natural cycle is better, and there are a lot of articles that say hormone cycles are not worse. There are no studies really that have ever said hormone cycles are better than natural cycles, but many of them will say natural is better, and many of them will say they're the same. I don't believe that natural cycles are better. I do believe there are some people that just don't respond well to the hormone cycles, and you can certainly consider the value of a natural cycle in them. I like the modified natural, which is the letrozole protocol, so that's what we do. And that's just because it's been shown to be better. And letrozole has also been shown to be better than natural cycles. I think we just reviewed that on the show recently. So yeah, that's what we do. So it's not a full hormone cycle because I don't think those are good. And it's not a full natural cycle because I think letrozole is better.
Hi, Dr. V and T. Happy Father's Day to you both.
Yes, thank you. Appreciate that.
I appreciate that.
Did you like my message?
Loved.
It was a good message.
Great.
I sent Tarek a nice message. Yeah.
Made my day, to be honest. It was better than the message I got from everyone I know. Yeah. So on Monday, June 13th, I had a 24 millimeter and 19 millimeter egg on my left ovary on day 12, my cycle, after taking Clomid 100 milligrams from day 5 to 9 and estrogen 1 milligram from day 10 to 14. My doctor decided to trigger on that Monday, June 13th. They administered 10,000 units of Pregno. We had timed intercourse from cycle day 12 to 15.
Okay.
Should I test for progesterone or wait to find out if positive?
Oh, I wouldn't bother testing for progesterone because you took Clomid and your levels should be more than adequate. We never test for progesterone. We do supplement vaginal progesterone in our IUI cycles, but no one measures progesterone in a natural or IUI cycle unless you're known to have a very low progesterone level, and that has to be very, very low in order for it to be a problem. So I would not bother measuring in that kind of cycle.
I'm 39 years old, have Hashimoto's, FSH at 2.23.
Oh,
would you have
TSH or FSH?
F. Would you have done anything different? Thanks for all you do.
I don't know what you did, so I can't tell you if I would do something different. So, I mean...
Oh, this is the same girl about the previous question. 10,000 units of Pregno.
Oh.
Way to find out, this is the same.
No, I don't think I would have done anything necessarily different. We probably would have tried the same thing. I think that's reasonable. That was the Clomid question?
Yeah.
Yeah, I mean, you need to make sure your Hashimoto's is very tightly controlled, but aside from that, no, there's nothing special that you would need to do that you didn't already do.
Hi, Dr. V&T. Can discontinuing 2 forms of estrogen pill and patches for canceled FET delay the start of your period?
No, actually, it should hasten the onset of your period. So get a pregnancy test if you haven't had your period yet. I have seen weird things happen. I once upon a time had a lady who had uh, zero response to stimulation, nothing. And she was on the meds for days and we could not get her to respond. And no matter what I did, it just didn't work. And then she stopped the meds. We stopped everything. Her husband had some of the worst sperm I've ever seen. And then she got pregnant with twins naturally that month. So you never know. Science and biology are amazing things.
Hi, Dr. B&T. I am 41 in a week plus a few days. 9 fibroids, 7 protruding into urinary cavity.
Wow.
AMH 2.3. In your opinion, is IVF truly my only option for possible conception?
Well, I'm never going to say IVF is your only option, and I don't know the units of your AMH, whether it's nanograms per mil or picomoles per liter. But if you have that many fibroids protruding into the cavity, you need a multiple myomectomy. And that's a lot of fibroids protruding into your cavity, which could do quite a bit of damage to your uterus. So you need a very thorough consult with an RE that actually cares about your outcome. And as far as the IVF, I mean, it's certainly a great option for you, but I'm never going to tell you it's your only option because there's always other options. So you could try IUI. There's donor options, there's surrogacy options, there's U options. But if you have 7 fibroids protruding into your cavity, the one thing you got to factor in is time. So remember, in a sequence like that, what we would typically say is make your embryos, get enough to bank so that you have enough that are normal, get your myomectomy done, make sure your uterus is okay. That's going to take months for it to heal. We normally make our patients wait a minimum of 3, preferably longer, and then you can start getting pregnant. So age will become an issue because you're going to need several months of IVF, months to wait to get into your surgery, depending on where you are, of course. And then you've got to wait months to heal. Like a year could go by before you know it. So definitely talk to an RE right away about the risks and benefits of each option and what it means for you in terms of time.
Any success stories with natural IVF, no stems?
Lots. One of my favorite patients, she is just a wonderful, wonderful lady. Their whole family is amazing. I love them. Local couple, they came to us. She really just had very weak eggs and ovaries. So we said, let's just do natural. We did natural. We made 1 embryo. She got pregnant. We did it again the next time. It took like 2 tries that time or 3. I don't remember now. She got pregnant again. Both of them absolutely beautiful kids, great family, lovely in every way, amazing people. So I very strongly support natural when these stimulated ones don't work. I think on balance, more eggs is better, but not for everybody, and certainly not if we're giving you lots of meds and you're still only getting 1 or 2. That makes no sense. It's cheaper and probably get better egg quality giving you very low amounts of meds or no meds and getting 1 egg at a time than pounding you with medication and still only getting 2.
I'm now pregnant with my second daughter. We would like to have a son next. Is it possible to do a genetic testifying to my 7 frozen embryos?
Not in Canada. If they're outside of Canada, you could, but they would have to thaw them, hope that they expand, which doesn't always happen. Then they would need to biopsy them, refreeze them, wait for the results of the biopsy, and then go ahead and thaw them again and transfer the ones that were male. You would have to move your embryos to the US if you have them here with us or they're in Canada. So we cannot do that in Canada, and we won't be part of it because it's a federal offense to do it here.
Do you recommend continuing all supplements, melatonin, CoQ10, NAC, etc. after an FET?
Yep.
If it's successful and into pregnancy?
Yep. Stay on it. Don't change anything. Pregnancies don't like adjustments. They like uniformity.
How long should I have to wait to complete laparoscopic endosurgery with you?
Well, I am doing everything humanly possible to get more OR time, but right now we are stuck with a combination of no anesthesia in Windsor, and we have we have no OR time because of COVID. So I actually am reinstigating my privileges at another hospital so I can do some surgery there. There was some stuff we were reading today saying that procedures that are related to fertility that need to be done for IVF, for artificial insemination cycles, may not be covered by OHIP. So if that's the case, we might be able to do them privately, but short of charging people for it, I don't have a way to fix that either. So we're still trying to figure all of this out.
Do you know if our eggs are genetically abnormal? Is there a way to check this before retrieval?
No. We can give you an estimate based on your age, and those estimates are pretty accurate, but that's the best we can do. We cannot tell you based on your appearance of the follicles or the appearance of the eggs, or even when we get them and turn them into embryos, we don't know until we do the biopsy and send it for testing. Even the appearance of the embryo is not predictive of whether or not it's genetically normal. Down syndrome embryos very frequently look beautiful under the microscope, top quality.
Do most IVF pregnancies have SCHs?
No, definitely not. So the question is, do most IVF pregnancies have subchorionic hemorrhages? And the answer is no. The majority are perfectly happy, healthy, normal pregnancies. Some do, but not the majority of them. By no means is that true.
Can you explain the procedure for freezing your eggs?
Yeah, so you go through IVF. We stimulate the production of your eggs. Once your eggs get to the size where they're mature, we extract the eggs and harvest them. We then freeze them. So they have to be cultured and kept stable, but then they get frozen, and then you wait. When you need them, we can thaw them. They have to go through ICSI. You need someone really good that knows what they're doing. They turn into embryos, and now you've got embryos. And then we transfer them. And then you can refreeze the embryos again.
Hi, Dr. Victory. What is the benefits to fresh or frozen transfer? What do you prefer to do?
So there are many, many studies on this now. It is abundantly clear that in the majority of cases, a frozen embryo transfer is better, because after the stimulation of IVF, there is too much manipulation of your estrogen and your progesterone. If your estrogen is very high, it can have significantly negative impacts on your success, your pregnancy risks, miscarriage, stillbirth, high blood pressure, preeclampsia, IUGR, small for gestational age, the list goes on and on and on. And if your progesterone is high, it'll prevent you from getting pregnant. So we try to avoid it for the most part. There are some instances where that's not true. Someone doing a day 3 transfer because they only made one embryo and they don't want to wait till day 5 definitely does not need to do a frozen embryo transfer. Somebody who is doing natural cycle IVF does not need to do a frozen embryo transfer. So there are instances where it's definitely not needed, and in some cases not even recommended. But for the majority of cases, a frozen embryo transfer provides you with greater control, greater safety, and in most studies, a higher or at least equivalent success rate. So because the safety profile is higher and you're at least getting the same, if not higher success rates, we advocate for doing mostly frozen transfers.
Hi, Dr. Victory. I did a round of Letrozole last cycle and got a positive ovulation test on day 15.
Awesome.
Unfortunately, it did not work, and we are on our second round. My question is, does a positive LH surge always result in an egg being released in a woman with PCOS?
No. So the problem with that is there is no way to know if your egg is technically released. The only true test of ovulation is actually pregnancy. So we suspect it does, but there's no way to actually know for sure that it does. It's a great question. It's one of the great mysteries of fertility, but there's no way for us to know unless you actually get pregnant. Some people will collapse their follicle, it'll turn into a corpus, but the egg doesn't release fully, or it was an empty follicle or something like that.
Great question here.
Okay, great question.
Hi, T. And Dr. V. But she started strong.
She did start strong. I'll give her that. Yeah. Wasn't strong. Yeah.
I recently went in for retrieval.
Okay.
Trigger shot taken at 8 p.m. Wednesday.
Okay.
And retrieval scheduled for Friday, 7 a.m. When I went in, I had ovulated already. Did the doc do something wrong?
Well, it depends on what your hormones were like the day before. That's a 35-hour retrieval. That's what we do. So if they knew that your hormones were beginning to rise ahead of time before they were supposed to, then they didn't do anything wrong, but they did their best to try and get the eggs out of you at a reasonable time so that you wouldn't have a bad outcome like you unfortunately did. If they didn't know, and sometimes we don't, because we're not, like, some places don't check your LH level. We do, but most places don't. Or I shouldn't say that. Some places don't. Then, I mean, they wouldn't know. Now, if they forgot to give you Cetrotide, or if you forgot to take your Cetrotide, I mean, there's a lot of different variables there. So I can't necessarily say it's one answer fits all.
You like this one?
I like this one. All right.
Is the Emma Alice test worth it? I've done 6 egg retrievals and only 2 have normal embryos. So I want to do everything we can to help implantation.
So ERA is not. Emma and Alice is reasonable. I just don't like iGenomics because they kept pushing that ERA test and it doesn't work, and we know that it doesn't work. So I would strongly advocate for using Fertility, because it's roughly about the same price, and I like their reports much, much better. But whatever you want to use. I mean, the bigger question is it worth figuring out if the bacterial composition of your uterus is balanced and healthy and appropriate and all that stuff? Yes, it is worth figuring it out, in my opinion. Does it matter if you use Emma and Alice or you use Fertility? No, it probably doesn't matter a lot. Choose whichever one you like. The one big difference, for Emma and Alice, you need an endometrial biopsy, which has its benefits, but sucks because it's very painful. For Fertility, you don't. You're collecting menstrual blood, so it's a hell of a lot less uncomfortable.
Hi, Dr. B&D. I have very light, short periods. I recently was prepping for transfer, taking Viagra suppositories 4 times a day.
Okay.
Couldn't get lining past 5 millimeters. What would you recommend for supplements and meds?
So this was one of the seminars I was at, and I think I ended up talking about as much as the speaker did. Okay, Viagra is good. PRP is really good. Human growth hormone is very good. Neupogen may be good, but they're not sure. Vitamin E, vitamin C, vitamin D have all been proven to be beneficial. Pentoxifylline may be helpful. Estrogen route, so transdermal versus vaginal versus oral. And in the worst case scenario, stim. So take Gonalef or Menopur or whatever you want to try and make your own eggs do the job that you're trying to. All of those have some evidence for them. And some of them have very good evidence for them. So those are the things you should try. PRP is very promising. It usually takes an extra cycle for it to kick in, but it does show some benefit.
How many betas does your clinic have women do?
Typically 2, just to make sure it's rising appropriately. So we'll do the initial one to test if you're positive, and then another one 2 days later to make sure it's rising properly, or 4 days later to make sure it's rising properly. Once we know it's rising properly, the next step is just waiting till your ultrasound. There's no benefit to doing serial betas, guys. It gets OHIP mad at us, wastes a lot of time and money, keeps poking you for no reason, and ultimately is not of any value whatsoever because it doesn't tell us anything. So, obviously if it goes down, we can't rescue it. And if it's going up, then you're fine. So there's really no value to doing extra ones. It's that ultrasound that's going to give you all the information you want.
It's okay.
I wasn't saying it wasn't.
Yeah. I want to take DHA supplements, but my OBGYN says that there is a risk that my testosterone level would be too high, and this could affect egg quality. How do you mitigate the possible negative effect?
Your OBGYN is wrong. That's how I mitigate the negative effect. Yeah. So DHEA, as long as it's stopped prior to an embryo transfer, has no impact on the outcome of the fetus whatsoever. So you don't need to worry about that. You do need to stop it if you're taking it to try naturally. I wouldn't. But if you were taking it to try naturally, you have to stop when you ovulate. As long as you do that, it's not going to have any impact.
Slightly jealous of this comment.
Okay.
You can have it.
Okay. All right. I'm ready. Give it to me.
Love you, Dr. Victory.
Oh,
you have a white heart. God bless you.
Oh, thank you. Well, I appreciate that. Tarek too, but we know that was what you meant when you wrote it. Thank you. That's very kind of you. And we love all of you guys out there too. This is really fun for us. We enjoy this and love the chit chat and the banter. So yeah, thank you guys for watching.
Hi, both.
Hi, both.
I skipped 3 people to go to the high both. How do you treat adenomyosis? Do you need to test this before an FET?
Oh, well, you can't test for adenomyosis. It's an ultrasound or MRI diagnosis. If they're testing you for adenomyosis, you've had your uterus removed. So that's not a good idea. Yeah, you need Lupron and Letrozole for 3 months prior to FET. And then we use those same endo supplements. So NAC, curcumin, resveratrol, and coenzyme Q10. There is no other way to treat it. Use a low estrogen protocol when you're doing your FET.
Tread carefully with this one.
Tread carefully? Okay.
I'm in Windsor area.
Okay.
But my doctor only has me on Lupron for my endometriosis and estrogen. Is this right?
Yeah, tread very carefully. Thanks for that one, buddy. Tarek will be departing the show soon. So listen, I don't know if you're referring to your gynecologist or if you're referring to a fertility specialist. I also don't know if you're referring to this in preparation for fertility or just for management of endo. So if you're on Lupron and estrogen in preparation for an FET, I don't do that, but that's not an unreasonable consideration. I just don't do that. I want to totally suppress you. So we use Lupron and Letrozole to completely eliminate your estrogen. And it's based on a study we reviewed here on the show. If you're using it as treatment for endo and fertility is not part of the picture, that is very appropriate therapy. And I think that I would support that 100%. I hope I didn't get myself in trouble.
You did a great job.
Did I? Yeah, I could see you like burning your eyes into my soul while I answered that one.
Everyone continues to learn.
Okay, that's good.
IUI number 1 failed.
Okay.
Does the second IUI increase chances?
Yeah.
Was on letrozole, overdrone, progesterone, mildly thin lining, nothing concerning. Thanks.
You want a screen share?
Let's go, man.
What's the battery life?
Full power.
Yeah, right.
Let's open a new app.
Uh-oh.
Don't worry.
All right. I'll screen share and show you the graph so that you'll understand what happens with IUIs, because it's kind of important to understand. It's a reverse ski hill, I guess. So there you are. All right, here we go.
I'm very excited for the drawing.
I'm excited for the drawing too.
It's been a while since this pencil came out.
I know. Okay, are we good?
You're lovely.
Okay, so if I select this guy and we do the graph, and here is number IUI, and here is, oh no, sorry, I did that all wrong. Here is,
No judgment.
Yeah, thanks for that. Here is percent pregnancy, and here is number of IUI. Okay, so 1, 2, 3, 4, 5, out to 6. So the curve basically looks something like that. So at the beginning, from like here to here, it's going to increase, right? But once you get up to somewhere around 4 or 5 cycles, this increase is very, very small. It should probably be a little bit more like that. And if you're under 35, once you get to 6, it becomes 0 after that. There is no increase in success. And once you're close to 40, that's actually happening when you're at 3 IUIs. So here it flattens out. So that's the curve. So first, second, third, regardless of your age, you're going to see an increase. If you're over 38, 39, close to 40, you're pretty much not going to see any benefit after 3 IUI. If you are under that age, you have up to 6 IUI to see a benefit. After that, it's 0. Screen share done.
Wonderful.
Are you going to stop or will I stop?
I'll stop it for you. Don't worry.
Yeah. I love drawing. It's kind of fun.
You've become an artist on the show.
More like a Picasso. I can't draw a straight line with
That's
my
right, you're
life.
Picasso.
Actually, you know what? The graph line is kind of straight. I'm not going to lie. It's not
That
bad.
bottom axis?
It's nice, right? Yeah. 10
10 out of 10.
All right.
High T and Dr. V.
There you go. Yeah. Yeah.
Large ovarian cysts. Like, they give me a real question here. Large ovarian cysts, 27 millimeters on monitoring cycle day 4 for planned FET.
Okay.
Spontaneous chemical pregnancy last cycle.
Okay.
Should I be concerned for this FET? Anything else I should do, measure, monitor? Thanks.
Yeah, I would get your progesterone levels and your estrogen levels checked. As long as they're normal at the start, you're fine. If they're not, don't go ahead. That's an easy one.
I left it for you.
Thank you.
Yeah. What are the causes of a failed first FET age 39 using donor egg and donor sperm? ERA and Emma was addressed prior to transfer.
Okay, well, don't do ERA because that's useless. So ignore the ERA. That could actually be the cause of your failure. So donor sperm and donor egg. Okay, so it could be a genetically abnormal embryo. Even though it was donor-donor, you could still have a genetically abnormal embryo. That's going to be the number 1 cause. Number 2 would be a problem with the transfer. So if they didn't do a good transfer because it's difficult. Number 3 would be something about you. Endo, you said you did Emma Alice, so probably not infection. Immunological problems, fibroids, polyps, your hormones weren't right, your thyroid has autoimmune issues, you've got antibodies, your vitamin D was too low, your iron wasn't right. I mean, there's a whole host of things. So those are the ones where I generally strongly recommend you get a consult with us because we need to kind of address that for you.
What protocols do you use for IVF with low ovarian reserve, AMH 1.1 picomoles per liter, and high DNA fragmentation, 32%?
Okay, so the sperm we would need to improve first before we did anything for you because that's a very high risk of complications like miscarriage risk and poor fertilization, poor blastulation. But from the protocol standpoint, I would just do a natural cycle for that because it doesn't matter how much meds I give you, you're only going to produce 1 or 2 eggs. So it's just easier to keep it natural. And I believe you actually produce better quality eggs that way.
I had my tubes removed after the birth of my second daughter. Is there a chance to become pregnant again through IVF?
100%. It's very easy. I shouldn't say 100%. I need to know more about you, but it's absolutely possible for you to become pregnant with IVF, even if your tubes were removed. You don't need your tubes for IVF. They're unnecessary. So it's very possible to do it.
What role does a high BMI play when completing an FET?
Depending on how high it is, it's a huge decrease in success. So anywhere from a low of 40 to a high of about 80 to 90% decrease in success based on how high your BMI is. It also makes the pregnancy much more risky and miscarriage risk, stillbirth risk, preeclampsia, preterm birth, stillbirth, even neonatal death is higher if your BMI is elevated. So there are a lot of risks associated with, having an elevated BMI. And I'm not saying that to be disrespectful to anyone. Believe me, I'm trying to lose weight right now, so I understand the struggle. It is always a struggle. It's tough, but it is necessary in order to protect you for pregnancy. And there are ways to lose weight. We hear it all the time. I've tried everything. It doesn't work. The reality is weight loss is math, and people can argue about it back and forth all they want, but it is math. If you're taking in 2,000 calories and you're burning off 2,500 calories, it is biologically impossible not to lose weight. You will lose weight. So it's all about input and output. So if you take in less than you burn off, you have to lose weight. And that's how people get shredded. And that's how the guys on magazines always have the 6-pack abs. It's because they actually eat less than they burn off. And that's why they look so lean and they have, everything showing everywhere. That's how they do it. Same thing for women. They're all eating less than they're burning off. So you're in a calorie deficit and you burn off any fat stores and sugar stores that your body has.
That's right.
That's what Tarek does. Yeah.
I burn 2,500 calories a day. That's my move.
You and I burn 2,500 calories eating.
Yeah. Absolutely.
Yeah, the 5,000 calories we had for dinner. Yeah. Well, we had a lot of rolls. That's
so
true.
It's 8:55.
Yeah.
Okay. And I just want to.
You want to rub in the battery?
I'll let you be aware that we have 46%.
46%.
Not bad.
Well, the show usually goes till like, 9:05.
You can be comfortable today.
That's right. I got your money, man.
Yeah.
Don't worry.
We're good now.
Yeah.
How many eggs are needed for IVF?
1. But it's very age dependent, sperm dependent, your health dependent. Is the embryo normal dependent? There's a lot of factors that go into it. So if you're super young, you could probably get away with 1. If you are over 40, you need a lot of eggs to succeed over 40. So it depends on many, many, many different factors. But we do have successes even with just 1 egg.
Should I have symptoms during the TWW after an FET? Trying not to test at home, but the fact that I don't feel any different is stressing me out.
No, you should not have symptoms in the 2-week wait. Yeah.
Hi, can we take birth control pills to induce a period after Lupron depot monthly shot?
Yep.
My RE recommended a swab for M2 annexin. What will this tell us? We have had 3 failed FETs and 1 miscarriage.
Nothing useful that I'm aware of, but I've never looked up M2 annexin and infertility. I'm sure there's a study out there somewhere. Maybe I'll look it up.
Is there scientific data to back up the supplements you stated? NAC, resveratrol.
Yes, we've reviewed it on the show before. There is scientific data to support that. It's in our natural endometriosis video. It's in a bunch of our videos. Yeah, we've talked about it in a bunch, but it's in the natural endometriosis video. So check that one out. That one has like 18,000 views
the one
now.
with Done Strong, the supplements video.
I don't think we reviewed the science behind it. Did we? Did we do a paper?
I don't know.
I don't think so. We've done a couple of videos with manuscripts in it that reviewed the different things that work. So I'm pretty sure there's the natural endometriosis one, and that's the main one that has it in there.
Will a fluctuating AMH between 0.42 and 0.9 and FSH of 13 disqualify from IVF age 39?
No, not at all. There's no disqualifying from IVF unless you're menopausal, and even then it's still possible, but it's very, 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 very difficult. So you're not going to be disqualified for sure. No.
What would be the best natural protocol with timed intercourse? 3 rounds of IVF only ever gave me 1 to 3 eggs. Would like to try at home.
What would be the best protocol with what?
What would be the best natural protocol with timed intercourse? 3 rounds of IVF only ever got me 1 to 3 eggs.
Oh, the best natural protocol, I would probably do nothing. I would just go natural. If you wanted something to boost your egg production, Clomid would be reasonable. You could take the shots for IVF, but then just have intercourse after you trigger. Any of those would be reasonable.
What do you believe is the most common cause of infertility? Nature, nurture, more common for males, females, unexplained? That's the question.
Wow. So the most common cause of IVF is actually ovulation disorders. So although now male factor is probably up there as a whole as number 1, because the female factors are broken up into different components, but the male factor is all just male factor. So male factor is probably number 1 in that regard, but strictly on a percentage basis. But I mean, ovulation disorders would be number 2. Is it nature or nurture? I'm not 100% sure how to interpret that, but I mean, it's biology. Can you put yourself into an infertility position? Yes. Smoking, drinking, drug use, obesity, poor health habits, poor choices, exposures to sexually transmitted infections. All of these things can render you infertile. But I mean, I don't think people are going out there saying, I'm trying to become infertile. So we don't blame anybody for this stuff, but it is possible to increase your risks of infertility with some of the life choices that you make.
What do you believe is the most common cause of infertility? Oh, sorry. Can an extremely narrow uterus cause extreme period pain? How does this affect fertility?
I don't know that an extremely narrow uterus can cause fertility pain, but there's no doubt that patients with a narrow uterus have a higher risk of miscarriage, and that has been shown. So it doesn't necessarily cause infertility, but it does cause an increased risk of miscarriage. Okay, annexin and IVF.
Do you want me to share this?
I'm going to have to look this one up. A possible risk factor, maternal and paternal carriage of the annexin A5M2 haplotype, a possible risk factor for recurrent implantation failure. Let's take a look at the abstract and see what it says. You can share this, sure. Is it up?
It's up.
So this is Journal of Assisted Reproduction and Genetics. So 63 people, small study, with recurrent implantation failure. RIF was defined as greater than 4 consecutive failed transfers of greater than 4 blastocysts or greater than 8 cleavage stage embryos. Wow, okay, that's reasonable. Fertile female controls, population controls, okay. Couples carrying the M2ANXA5 haplotype turned out to have a significantly increased relative risk for recurrent implantation failure compared with female fertile controls. It was quite elevated. That's 1.81, so an 81% increased risk. Wow. Male partners were comparable. Huh. I've never seen that before, so thank you for bringing that to my attention. I'm going to need to talk to fertilicists now. That would be interesting to test for. We're going to have to look at that. Yeah, I need to see more studies on it, but certainly looks interesting. So I'll read this one and we'll figure it out. 902.
You just got that much better.
Well, you know what? That's why we do the show. I learn something every time. Well, here's another. Actually, you know what? Just if you go back on there, there's other studies that say it's not. You can see it right in the thing right there. Annexin A5 promoter haplotype M2 is not a risk factor for recurrent pregnancy loss in Northern Europe. Who knows with this stuff, right? So we'll look it up. I'll have to decide if it makes sense or not.
902, 903.
Any amazing questions?
I think the computer's still on. So that's amazing.
Yeah.
Thank you for searching for the M2 Annex article.
Yeah, no problem. Interesting, but not convincing. I mean, already in 2 seconds, I found 2 studies that say, 2 different things. So,
want to do one more?
One more. Let's do one more.
Okay.
I don't feel that was like a strong finish.
Yeah, we need a strong finish.
We need a strong finish. Yeah.
Let me see if there's Facebook, YouTube, what are they saying? Here you go.
Okay.
In regards to medicated cycles,
yeah,
is having a dominant follicle at cycle day 11 at 24 to 28 millimeters too early? Ovulation occurred naturally on day 13 and 14 in the medicated cycles with letrozole.
That's pretty early, but I mean, if you haven't released it yet, you might be okay. I mean, I like kind of a minimum 12-day follicular phase, so that's not terrible. You might be okay with that. 11 would be a bit short in my opinion, because that's like a 25-day cycle, which is kind of compressed. So it doesn't really give your endometrium sufficient time to fully develop and mature. Good question. Never had that question before.
Never had it.
Okay, folks. Well, Tarek beat me. I bet him his laptop wouldn't survive. He did some sort of weird voodoo trickery, and it did survive. So I owe him some money. So I hope you all have a wonderful night. And I trust that you guys will stay safe and be well. And we will be back next week, I think, for the show. And then I'll be in Italy. So I might have Jen Strong do the next one, or Darcy, or maybe I'll get Fred to host Fertility Factor Fiction. That would be good, eh? So we'll see what happens. I hope you guys all have a great night. We'll see you again on Fertility Factor.